Hello everybody, this is Professor Turpin. I'm just going to go over chapter 60, kind of short in this little video, to kind of give you an update on malnutrition or what they consider undernutrition and obesity and some of the factors that play into that. At the national level, we have nutritional standards that are established for health promotion and maintenance. We do have dietary guidelines for Americans. Not every country has that. Obviously, we're trying to improve the health of our country, primarily as we've talked about as it relates to obesity. But on the flip side of that, we still have lots of segments of the population who are malnourished or undernourished, related to, just plain old hunger. That's why the United States government and state governments have set aside monies, particularly for, providing relief for hunger initiatives, and particularly things like the school lunch program and in some cases school breakfast programs, to really address childhood hunger. And then, some of the needs of senior citizens who aren't able to take care of themselves well in terms of feeding and or preparing their meals. We have programs and things in place like Meals on Wheels. Some of the main guidelines for Americans are really good from the Department of Agriculture in terms of the My Plate program that I'll talk about. And I want to talk about cultural awareness and aging considerations for the geriatric population as it relates to nutrition. The My Plate program is one of the better things that we have in terms of visual educational capability for all age groups. It's nice in the sense that we have good direction and guidance on not only what types of foods and the categories that we should be eating at each meal, but also the proportions. And this is a big issue in our country because we tend to have higher proportions of items that aren't good for us, and the cost of foods are cheaper for fast foods and things. And people have grown up in different areas of the country, and particularly here in the South, as we have looked at in terms of some of the problems, a lot of people haven't been educated on really proportion control. And so, having this as a visual teaching method that can be done at health departments or in a doctor's office or with a nutritionist is a very valuable thing. Sometimes visually being able to plate your own meal gives you an idea better of how that really should look and what you should really be doing versus someone just telling you. So if you haven't ever looked at that, go to choosemyplate.gov and take a look at that. It will help you give a better information to your patients on how to do their own meals. All patients that we deal with on the inpatient side in doing clinicals, when they're admitted, they have to have a nutritional at-risk screening done as part of their admission assessment. This is a function that in most hospitals the nurse is responsible for, and it's predetermined negative triggers that we are to look for and screen the patient from the standpoint for the dietitian to determine if they're at risk. It may be things like weight loss that you identified a certain percentage. It might be someone that has certain blood work that indicates that they're not nutritionally sound. It can sometimes be, that it's a new onset diabetic that is clear they're going to need educational nutrition. It might be somebody that's been NPO for a certain amount of days in the hospital and getting treated for something that's not resolving, and so dietary needs to be consulted. And so putting in these nutritional at-risk factors in the electronic system generates an order for a dietary consult, and then the dietitian begins to do a more in-depth full screening or full assessment from a dietary standpoint. As we know, a lot of people in our country are obese. That does not mean that they're well nourished. They may be malnourished because of the lack of proper nutrients in their diet. And on the flip side of that, someone who is very thin, although they may be in a thin state, they may have very healthy eating habits and may be well nourished. So size, height, and weight are not always the indicators of your nourishment level. And as we learned in the last few weeks about patients gaining weight with edema, sometimes you go to weigh somebody and they maybe are in the overweight or obese category. That might not be their norm if some of that edema is off of them. So you have to kind of consider a lot of different things when you're looking at weight as a measure. Also, you want to assess the patient's physical presentation. Do they look weak? Are they able to physically participate? Can they swallow well? Can they chew food well? Do they have an appetite? Do they look physically healthy? Do they look pale? As if they might be anemic. Different things that you may assess all through a physical assessment on these patients may give you indications. Presence of wounds is often an indication of poor nutrition. And chronic problems with their intestinal tract can lead to malnourishment as well, and we'll learn more about that this week. You've seen many laboratory studies that look at this. Some of the key things that people do lab work on to assess nutrition may be, particularly albumin levels and prealbumin levels. Always remember, if you're looking at those two things in a patient's record, albumin level will tell you sort of the protein status of the patient. But prealbumin actually is a much more sensitive measure to determine whether someone is malnourished or well nourished. So if their prealbumin status is in range, they're probably in a better situation. So always make that your gold standard for what you're looking for in terms of protein status. There are many influences on nutritional status, and we're going to talk about several, but I will say cultural and socioeconomic status are a very big issue. We may have certain foods that we eat because in our culture that's the norm. That may or may not be the healthiest thing for us. We've learned that from living in the South and some of the things we've already looked at so far. But other cultures that we don't see as much of have other different practices that may be positive for nutrition or may be negative. And so assessing that fully in terms of what their normal ways of eating and what their culture recommends in terms of eating practices and sometimes religious eating practices as well may have an impact on nutritional health. Socioeconomic status we know is a huge thing. Do people have money to pay for their food? Do they, live in areas of the country where they have access to fresh foods and vegetables or not? So lots of different things along those lines have an impact. These are several nutritional assessment considerations by aging, and I'm just going to run through a few of them. Remember, patients that are elderly, they have decreased taste and because of that, often decreased appetite. They don't have the same ability they used to chew because of loss of teeth or poor fitting dentures. Sometimes they don't have the money to go replace the dentures, so they have to make do with what they've got. They have decreased pressure in the esophagus because of their sphincter tone being lost, which can sometimes lead to hernias, and aspiration risk is big for elderly patients. They have thinning of abdominal walls, so when you're doing an assessment, you can do easier palpation on their abdomen often, and you can also sometimes visibly see peristalsis taking place through the skin. They have decreased sensation, which is not a good thing. A younger person would know when they're having abdominal pain, some, may be very conscious of having constipation and different things like that, but because of decreased sensation, may not recognize when they're having intestinal problems. The gastric mucosa also atrophy, and this causes decreased blood flow, or it actually is caused by decreased blood flow to the gastric mucosa, because of some of the blood flow issues we've already talked about with atherosclerosis as you get older. And so this causes lack of absorption of nutrients sometimes in the stomach. So even though they're eating well, they may not be absorbing everything that they need to. Intestines obviously slow down. We have decreased digestive enzymes, so less ability for absorption of fat-soluble vitamins, and if you don't know which ones those are, you may want to look those up. Decreased liver size, we talked about the other day, in terms of they may have build up toxicities to drugs that are metabolized by the liver. And then we know that they have decreased muscle tone, which leads to constipation, incontinence, and sometimes fecal impaction. Their pancreas is less functional, which makes them more problems with absorbing fats, and also with being susceptible to developing diabetes type 2. These are just some other nutritional disorders that are associated with malnourished patients. The protein-calorie malnutrition is something that is, those different three types are very common in underdeveloped countries due to intestinal infections being very prominent because of poor food and water conditions. Other long-term nutritional disorders can come about because of cancer, kidney disease, and neurological diseases. If you don't remember that you're supposed to eat, then obviously you may not. There are other types of patients who need total enteral nutrition, meaning through a tube feeding. And then there are other patients that have eating disorders such as anorexia nervosa and bulimia that I'm sure you've heard a little bit more about. If total enteral nutrition is provided, that just means that they are getting feeding through some type of a tube that goes into their GI system. There are short-term feeding tubes are usually through the nasal route and down to the stomach. And then intrastomal tubes are ones that actually go through a hole in the abdominal area that is surgically placed and is more of a permanent long-term feeding tube that's safer for staying in and being used. This is kind of some information about assessing for obesity. We use body mass index as a measure of obesity. We've talked a little bit already about how we teach patients better habits with obesity. Of course, the main thing is to focus on teaching obesity, prevention of obesity as early as we can. And particularly before people reach adolescence, if possible. And then there is ways to treat obesity, whether that's non-medical approaches, drug therapy, and then surgical management. These are a few of the surgeries that can be done. This is gastric restriction, where there is a small stomach pouch made in a band, or you hear people talk about the lap band procedure. Then there is a gastric bypass surgery, where they literally loop a part of the intestine to totally bypass the stomach so that food never always has to be tiny amounts, because it's just totally not going to have an open stomach for it to go in. And so that is kind of the most extreme type of surgery that can be done. This is a nice little website from Novant Health down in Forsyth Medical Center that shows kind of their program for bariatric surgery. And there is also such a thing as called gastric sleeve surgery. Key considerations if you have a patient that's had bariatric surgery, these are just a few things to be aware of, would be typical for their care. And then Here's a few more. Be aware of some of the